and but Scion did not work. So I exchanged to the field IFC, and after several attempts, the field IFC crossed this region, okay, like this. However, the problem was I could not advance Corsair anymore. Okay, I could not advance Corsair anymore. Okay, next.
Corsair stuck in the lesion that you had to cross with the XT?
No, I can
yes,
can show
this is field FC. Field FC. And you know, the field FC is going somewhere, but not in the true lumen of the right coronary artery. Maybe might be in the left atrial branch.
Next.
Okay, next. And then I extended the wire, field FC, to 300 centimeters, and then exchange the Corsair to fine cross, long fine cross, and the long fine cross advanced more than Corsair. However, I could not advance anymore. So the next, I took the OTW 1.25 millimeter balloon from Terumo, Ryujin, OTW 125, and then this balloon, OTW balloon, gradually going further. Okay, and I did balloon dilatation by 10 atmospheres here, and then next, and here again, and again, a lot of dilatation, and then I could successfully pass the Corsair. Okay. Next. But after the tip injection, you know, this patient's right coronary artery has a very complex anatomy. So at the upper side of the Corsair, I can see some bigger branch, you know. Next. And from the left coronary injection, again, we can see some connection. So I took the field FC again and passed the wire to the upper side branch. This is not a good. Okay, next. Next. This is again not a good vessel. Okay, and this is a good vessel. You know.
Run.
What happened? How did you get to that vessel? It just popped in?
This is, I think this is, should be the true lumen of the right coronary. However, after passing the Corsair, next please. Okay, I push the Corsair further. Next. And then exchange the wire to Miracle 3. But again, the wire was going somewhere. So still by now, I cannot find the true lumen of the distal right coronary artery. Okay. Totally different.
When the wire jumps.
So I am now in a very difficult situation.
To continue or not?
Yeah.
To continue or not the procedure?
Honestly speaking, I want to quit the procedure because I spent already 1.5 hours and maybe contrast for the 300 cc.
More or less.
So at this moment, yes.
Would you consider to go now antegrade on the right coronary, because it looks like, I know that you had no clear stump, but it's more clear now. If you you may consider to go antegrade on the right coronary.
No. I think that is just a breach collateral.
Yes, a breach.
So we cannot identify where is the entry. That is a breach collateral. So the antegrade approach should be very difficult, almost impossible. So any good idea from the panelists?
A little bit of contrast. Hazy
It's maybe peri-adventitial extravasation. So what is the next step, Saito-sensei?
So I have no idea at this moment. So I have to quit the procedure.
I think he is a young patient with good surgical conditions, low risk. The EURI score is about less than 1% for this patient. So we are thinking about quit the procedure and send this patient for surgery. What is your opinions?
Can you hear me now? Yeah, Major.
Yes, I can hear you.
Okay.
I can hear you.
Okay. I would like to ask Saito, wouldn't you try at least for a while to open the right to the integrate approach? I know it's really hard.
Okay.
I think he's afraid he's going to go into
it's very hard,
bridge collateral.
And yes, that is bridge collateral.
Bridge collateral.
Yeah.
And there is some risk.
What you can do is maybe try with another wire to go through the cursor. So take the filter XT out. Oh, you have now Miracle 3, right? Do you have
Miracle 3? This is Miracle 3.
Miracle 3.
Yes.
So now that you crossed and you can move the cursor a little bit, can you try again with filter to find the true lumen into the mid-right? Or parallel wire?
Okay, I will show you the angiography again. Both.
You the right?
No.
Try a parallel wire and a retrograde approach.
Simultaneous?
Simultaneous.
Simultaneous.
Okay, go.
Go?
Just a moment. Okay, go. Okay, this is anatomy.
Okay. Are you in the true lumen, the LAD? What is the place that you think you were in the false lumen when you were coming through the LAD?
No, I couldn't enter the...
It was impossible to cross the occlusion point in the LAD, Fausto. The guide wire stopped right in the point of the occlusion.
Yes.
Do you think you were in the
without the conditions to go forward.
Do you think you are in the false lumen since the occlusion?
No, I couldn't enter any part of the wire into the occlusion site. The entry plaque was so hard. So I took Confianza Pro, but that wire did not advance anymore. So I stopped
the miracle
to continue.
It looks like the Miracle tree is now pointing to the right coronary artery. If you take it and redirect it, or use a parallel wire on the retrograde approach.
Parallel wire on the retrograde approach? It's impossible. Okay.
By the way,
this is I'm handling the.
You're fishing for the right entry.
No, because I did tip injection in this branch. Oh, okay, I will show you.
Okay.
We have a question here by Dr. Matos.
No.
Professor Saito have the worry of
the
support of echo,
maybe.
Or the worry about tamponade here.
No.
Further? Retrograde. Back.
Yes, this is a tip injection. This is in the small branch. So I think that this distal right coronary artery is not connected.
Oh, I see.
Okay.
So do you think you get success to LAD, to open LAD or not? LAD, only LAD. Let's forget the right.
We tried the LAD initially.
I tried the LAD.
I tried the LAD.
He tried hard to open the LAD. But the guide wire couldn't cross the point of occlusion.
Yes, you can come back.
I'm going to show you the attempt to cross the LAD to give you an idea what Dr. Saito have done in this.
summarize this case, I think that what we're seeing here, that the antegrade approach in the LED was not successful. And I don't know how much time you spend on the LED. I mean, the impression that Fausto had was that you should work more on the antegrade approach on the LED. But if you exhausted all the wires and the time, then I think we have to make it a call and to say that this is not going to be an easy ride on the LED. The retrograde was attractive initially, but I think the long segment that you're missing and the nature of that distal ride is not favorable for this one as well. So it does leave us with probably more than an hour and a half of an attempt, radiation, contrast, and probably you should do the right thing to send the patient to surgery.
Yes.
Any other comments from the panelists?
That is my conclusion. But if you
I think
have
it was
any
fair
other,
assessment. You
good
give it a fair
idea.
chance, and then it doesn't work. It doesn't work. He has surgical option. He should exercise it.
Okay. Is the patient feeling okay?
Pardon?
Is the patient doing okay? Clinical
Yes,
patient?
doing okay.
Okay.
And
The patient?
at this moment, I have no complication.
So, do you think
The patient
if
is
you,
stable.
Saito, do you think if you see a case like this again, would you try or would you send this patient to surgery at the beginning?
I want to send this patient to the surgery because you know I have no any other good idea for this patient by
right
treating
now, but
by PCI.
Let's say an example.
But
if you go back to Japan, and then next week you're in your lab, in your busy lab with 6 CTOs a day. So if you see a patient like this, you would send him to surgery, or would you try?
No. Even this procedure was done in my hospital. I will not try anymore.
Good.
It's
That's
not a
very
good idea for the patient.
Yeah, you see that sometimes it's harder to stop than to open the total occlusion. But I think this is where we need to intervene and make a decision. It was fair to give it a chance. And we said if it's going to work, it's going to work. But it doesn't work, I think we have to call it, because this is not like, the right is going to be very, very tough. The LEDs not make any headway. So I think there is no point to throw more contrast, radiation, time, and
Is teaching
I think we learn more with unsuccessful cases. Sometimes we get success.
Okay.
So
Shall
I
we
think
take
it's a very good teaching point here and how we should
have to
avoid
check any
CTO
complication.
procedure.
Okay.
The time is going fast.
maybe I'll just ask one question. Did they had a CT ahead of time? Because I think that the comment that Gilberto Nunes said was very important. In a case like that, you'd like to have the CT
the lower part of